Good morning, all. I am Dr. Rekha. So, I'll be talking on the next very important step in SICS, that is the anterior capsulotomy. So, at the outset, let me thank KSOS and the Scientific Committee Chairman, Dr. Rajiv Sumaran sir, and the instructor of this instruction course, Dr. K. Mahadevan sir, for giving me this opportunity. So, let me share my slides. Okay. So, as you all know, anterior capsulotomy is a very important step in SICS. It is said that a properly done anterior capsulotomy means the surgery is half done. So why it is important is because it is crucial for a successful and safe lens extraction and IOL placement. So before learning how to do an anterior capsulotomy, you should have some anatomical points in your mind. First of all, regarding the thickness of the anterior capsule, the anterior capsule is just 14 microns thick. So when you do an anterior capsulotomy, always be careful not to disturb the underlying cortex. Also, overall, the equatorial diameter of the lens is 9 to 9.5 millimeters. You know, the zonules are attached to an area 1.5 millimeter wide in the pre-equatorial region. So practically for an anterior capsulotomy, you're getting only the central 6 to 6.5 millimeter area, which is called the zonule free zone. So if you go outside this zone, you're likely to damage the zonules leading to zonular dialysis. So always limit your capsulotomy within this area. So prerequisites for a good anterior capsulotomy are, you should have a well-dilated pupil, well-formed anterior chamber with OVD to flatten the anterior capsule. This is also very important. Always maintain the anterior chamber. Good echinacea, and also avoid hypotony. Your eyeball should never be too tense, nor should it be too soft. It should be firm in consistency. And from where to do the capsulotomy depends on the surgeon's preference. There are some who do through the side port and there are some who do through the main wound. But it is always better to do through the side port because when you go through the main wound, there is more risk of OVD leakage and the anterior chamber becoming flatter. Coming to the types of capsulotomy, basically you have three types: Cann-Oppenau capsulotomy, continuous curvilinear capsulorhexis or CCC, and linear or envelope capsulotomy. The third one is not popularly done, so I will be describing only the first two techniques. So, a few words on capsular staining dyes. Why you need a dye to stain the anterior capsule is because it helps to visualize the anterior capsule better when there is no red glow, as in a mature or hypermature cataract. As you can see in the first picture, you can very well see the rim of the anterior capsulotomy against red glow, which is in an immature cataract. But in the second picture, which is a mature cataract, it will be very difficult to differentiate between the capsular rim and the underlying cortex. So for that, you need to stain the anterior capsule using special vital dyes. The most commonly used is trypan blue in a concentration of 0.6 milligram per ml. ICG is also available, but it is a bit costlier. So what are the basic steps in anterior capsulotomy? First is side port creation, which has already been discussed. Then through the side port, inject an air bubble in order to protect the endothelium from damage caused by the dye. Then inject the dye under the air bubble using a 26 gauge cannula. You can wait for a few seconds, 8 to 10 seconds for the capsule to take up the stain. Then wash the excess dye with Balansol solution. Reform the anterior chamber with an OVD with a good high viscosity OVD to make the anterior capsule flat. Coming to Cann-Oppenau capsulotomy. It's a very useful technique for beginners, and the advantage is that it can be used in all types of cataracts. And it is the preferred technique in calcified or fibrosed anterior capsule, where it is very difficult to do is capsulorhexis. It is also the preferred technique in intumescent cataracts, where you have high intralendicular pressure. So when you attempt a CCC in such cataracts, there is always a chance of peripheral extension of the capsulotomy. And it's also easier to master. This is usually the first technique learned by beginners. Coming to the technique, it can be done either with a commercially available cystitome, or most commonly it is done using a bent 26 gauge needle. So basically what you do is you create multiple punctures or small radial cuts in the periphery, which are then joined. So this is how you create a cystitome from a 26 gauge needle. Using a needle holder, you first bend the tip of the needle just 1 millimeter away from the tip with the bevel outwards. at around 90 degree. The second bend is made near the hub around 2 millimeter from the hub in the opposite direction. So basically you have two bends, one at 90 degree, the second bend at 110 to 120 degree. Coming to the surgical technique. So here you can see already the anterior capsule has been stained with the dye after filling the anterior chamber with air bubble. Then you wash away the excess of dye and refill the anterior chamber using a good OVD. So all these are done through the side port. Yes. So this is how you do the can opener capsulotomy using the bent 26 gauge needle. You can see you create multiple small punctures at the periphery which are joined. So here you can see there are multiple punctures which are being joined. So you may need around 30 to 40 punctures in order to complete the anterior capsulotomy. So here you can see it's almost complete and the central flap has been detached. So what are the disadvantages of a can opener anterior capsulotomy? You can see that the edges are ragged. They are not smooth or continuous. So there is always a chance of radial extension into the periphery, especially during nucleus extraction and IOL insertion, which can lead to zonular dialysis and extension to the posterior capsule leading to posterior capsular rent. And also the capsular bag is less stable, so that postoperatively after IOL insertion, one of the haptics can actually prolapse out of the capsular bag. And there is always a chance of capsular tags being there, so that when you do irrigation and aspiration using Simcoe cannula, you can catch hold of these tags. Now coming to continuous curvilinear capsulorhexis, which is the most popularly done technique. It involves a controlled tearing of the anterior capsule, which produces a smooth, strong, regular, continuous opening. It need not be circular exactly, but it has to be continuous and smooth. Rhexis in Greek means to tear. So technique of CCC, it can be done again with a cystitome or using a special forceps called the Utrata forceps. So the first step is you create a puncture at the center of the anterior capsule, then you extend it horizontally towards the side and you create a triangular flap. Then how you continue the rhexis is by two methods. There are two methods of tearing the capsule. Picture A is tearing by shearing force, where you can see that you catch hold of the flap near the junction of the torn capsule and the intact capsule. And the direction of the pull is in the direction in which you want to create the capsulotomy. That is circumferential to the pupillary margin, you pull. The second one is tearing by ripping force, where you catch hold of the flap near the origin of the flap and the direction of pull is perpendicular to the direction in which you want the capsule to be torn. That means the pull is towards the center, that is centrifugal, centripetal. But this is not a preferred technique because there is less control, so that the capsulotomy can easily extend towards the side. Now we'll see how rhexis is being done using the shearing technique. So here again the anterior capsule has been stained with dye. You can see using a 26 gauge bent needle, that is a cystitome, you create a central puncture which is extended towards the side. Now you can see a triangular flap has been created. So always make sure that you keep the flap flat on the intact capsule. Never allow it to roll. Always keep the flap flat. And you catch hold of the flap near the junction between the torn and the intact capsule and pull it circumferentially. Now it's almost complete. You can see that. Yes, the central flap has been removed. This technique you can again do with the Utrata forceps. It is a special type of forceps where you can see at the tip there is a small bend which helps you to catch hold of the flap firmly. The technique is actually the same, that is using the 26 gauge needle, the creation of the central puncture and the triangular flap. The initial step is same. Next, through the side port, you introduce the Utrata forceps and catch hold of the flap. And you continue the same technique, that is you tear the anterior capsule using the shearing force. And you can see that this is a faster technique and there is better control of the direction of the pull. The only disadvantage is that you need practice to do this, and also since you're introducing a larger instrument through the side port, there is a chance for more leakage of OVD through the side port. So what are the advantages of a CCC? The edges are smooth. It prevents radial extension, and you get a very stable capsular bag. Postoperatively, the IOL will be very stable. You can do a very safe cortical wash, and there is better centration of IOL. And in case a PC rent occurs and you want to keep a sulcus fixated IOL, the rim of the anterior capsular rhexis helps to support the IOL. But the disadvantages is that it has a long learning curve. And also I had already mentioned that you should be more careful when you do this in a hypermature and intumescent cataracts. Due to the high intralenticular pressure, there is always a chance of runaway rhexis. So the take-home message in an anterior capsulotomy are: limit your capsulotomy to the central zonule free zone, which is a 6 to 6.5 millimeter area. Always keep the anterior chamber inflated. Use a sharp cystitome. It should be always centered and it should have a regular rim. So thank you. So once again, I thank you all for giving me this opportunity.